Dear colleagues, it is a great pleasure for me to be here at your congress. My name is Dragan Topich. I'm coming from Institute for Cardiovascular Diseases, Dedinje, and I will say a few words about intravascular ultrasound. As we all know, intravascular ultrasound represents the first imaging technique in interventional cardiology. With its excellent image quality and spatial resolution, IVUS has for more than 2 decades provided complementary diagnostic information to coronary angiography regarding the dimensions, structure, and lumen of the blood vessel. We are all aware about angiography that has much less information than the intravascular ultrasound. As we can see here, this is a Serbian military scout, and his aim is to be closest to the enemy and to count the soldiers, the horses, the cannons. And on the other side, in modern warfare, we have drones, we have AWACS. So maybe we can say to the guys from Boston to equip a new IVUS with a non-compliant balloon or IVL. What are the main issues with IVUS? Main 3 questions. First is one, how the long is lesion. The second one is plaque morphology, plaque characterization, and does it need to be modified prior to stenting? We can see if there is a lipid or a fibrotic plaque, or it has a certain amount of calcium. And the third question is, what is the vessel size and what size of the stent we required. After stent implantation, we must check for the geographic miss. It means that we must cover the whole lesion and also to check the edge dissection. After that, to check malapposition, good apposition of the stent on the artery wall, and on the third place, to check for the optimal stent expansion. So we have so much randomized trials, meta-analysis, and we can see here that in the latest European guidelines, it states here that intracoronary imaging guidance by IVUS or OCT is recommended for performing PCI on anatomically complex lesions, in particular with left main, true bifurcation, and long lesions. We are all aware about the EXCEL study, which is the largest randomized study which compare PCI versus CABG for left main disease. And on this left side, you see the percentage of IVUS performed in the study. IVUS was not mandatory, but strongly recommended. So pre- and post-stenting was performed in around 45%. And what is most important is that performing the IVUS leads to changing the strategy. In what way? After IVUS, to use larger balloon, to have a post-dilatation once more, or use higher pressure for post-dilatation, and also to treat under expansion, which is not visible only with angio. Noble trial is the second largest trial. Also, there was high penetration of IVUS, but pre- and post-IVUS was performed in less percentage of patients. We can conclude that when we perform IVUS, we have much smaller rate of target lesion revascularization, new myocardial infarction. So that was the reason, one of the main reasons to put IVUS in 1A. And now I want to tell you something about Noble trial, just quick reminder. So here is a banana skin, and watch carefully. We had to for inclusion criteria, significant left main lesion, also well known here, and when they enrolled the patient, there were local interventional cardiologist and cardiac surgeon determined that equivalent revascularization could be achieved with CABG or PCI. Exclusion criteria was additional non-left main complex lesion, chronic total occlusion, and calcified or tortuous vessel morphology. It means that if the lesion required rotablation, it wouldn't be enrolled in the study. We see here percentage of diabetes, and so also the principal finding was in favor for CABG because of well-known Achilles heel of percutaneous coronary interventions, which is target lesion revascularization. These are 5-year follow-up results. Again, we have IVUS before 47% and after IVUS before 47% and after 74%. So here we have interventional cardiologist. If you can say, or when you must choose IVUS before or IVUS post, what would be your answer? IVUS post or IVUS pre? Post, yeah. Maybe my answer would be IVUS before. So in complex calcified lesions, we have when you perform IVUS post, you do not, you don't have possibility to use IVL, cutting balloon. And if you have a good information pre to plan your strategy, but I must recommend the IVUS pre and IVUS post. So when we are reading such papers with really big clinical trials, we always asking ourselves, what is complexity of that patient which enrolled in the study? How was the angiography? How was that lesion? And now, after 10 years, and I must rely on your discretion, I will show you the films from the Nobel trial, and what happens in Ruse stay in Ruse. So when we remember now exclusion and inclusion criteria, on this angio we can see that circ is chronic total occlusion. So it is exclusion criteria, but that patient went into the study and this was the final result. This patient has one additional complex bifurcation lesion, a site of long disease over the left main, and they treated this with a mini crush technique, and they first diagonal was occluded after intervention with, I think, peri-procedural MI. This is additional patient, heavy calcified left main, dominant circ. So my question is how that interventional cardiology in that hard team for the study choose and give a green light to have this patient in the study, because this is high risk complex PCI. Also here we have heavily calcified plaque in the left main, and there is I think probably good apposition but bad stent expansion. We do not have informations about rotablation, about using the cutting balloon, changing strategy after IVUS. And we can go to another patients here. It's a subocclusion of proximal LED, complex lesion with good final result. Also here, it is very complex lesion with possible very big problem to wire the LED. And these cases were treated only with plain balloon angioplasty and without IVUS. I was hired to calculate the syntax score for the Nobel study, so I choose some of that highly complex lesions just to show you how that the whole patient population was, of course, there were, you know, much less complex patients, but I choose to show you the most complex patient here. So here you have a heavily calcified left main. This is a rota case, and this was the final result after plain balloon angioplasty. You can see here there is a residual problem in the proximal LAD. Also here, heavily calcified left main. I choose that AP cranial. You see here, stent dislodgement while they try to put it on ostial circ, but it went downstream to the diagonal one and they just left that. Also here, we have also heavily calcified left main, and this was problematic final result regarding the stent expansion and apposition. So in next few angios, these are the patients which I had only diagnostic angio. So we don't know if that patient went to the cabbage group or PCI group. But for sure, when you have in the cath lab such case, you can only cry, you know, because it is a very, very complex procedure. Also, these patients are also very complex PCI, so we must say that a certain amount of patients in Nobel study was very complex anatomical features. I have maybe some additional images. So I want to show you one of our patients. It was the ordinary patient scheduled for elective PCI left main LAD. So we performed the IVUS. Before the procedure, we saw here wide distal landing zone, then more than 4 in diameter, heavily calcified long plaque starting from the ostium of the LAD. There is here is the sarcoplex, also tight stenosis here at the level of the diagonal branch, and heavily calcified plaque here with 360 degrees of calcium. So on the basis of IVUS measurement, we put in mid-segment, we put first drug-eluting stent 4.020 and with overlap 5.0 after pedalitation. So on the IVUS, that was the final result. We have small apposition on the distal landing zone. We have good apposition at the point of the much hard calcium, but we tried to open that stent some more, and we choose balloon 4.5, which was, and we were pretty aggressive here. So perforation occurs, which sealed with prolonged balloon inflations, because our aim was not to put a cover stent in the proximal LAD, and we managed with prolonged dilatation to seal this perforation. Of course, the patient was screaming in pain, but we did it and we finished the intervention. And this was the acceptable final results. And one additional, after thoroughly, we look in the IVUS. In the part of the lesion, there was combination of positive remodeling and negative remodeling. And in the segment of negative remodeling, we had coronary perforation because our 4.5 balloon was too big. And the last case I want to show you, for these complex patients, we must follow them because then we can see the quality of our work during the years. So it was June 2008. At that time, young patient, 35 years old, his father died at the age of 40, preserved ejection fraction and non-STEMI in March 2008. Syntax score was 33, and the decision of our heart team was PCI, LAD, circ, and RCA. Of course, after that, reinterventions were in 2015 and 2019. So this was the film, this is film from 2008. You can see here a lesion in the mid-distal of RCA and one lesion before crux, and this was the result after stenting. On the left side, we have a long diffuse lesion in the LAD, which was treated with two drug-eluting stent overlap. You can here appreciate that expansion stent is suboptimal here. And on the circ, we had proximal lesion, then the lesion on the obtuse marginal 1, and occlusion of the distal circ with significant distal OM branch. So our operator was exhausted, and he put just proximal stent. And this is the angio of 2 years ago. We have here right. In the meantime, he received, with first intervention, 9 stents and 1 BVS down the mid-LAD stent, and he came with unstable angina and this proximal lesion of LAD. So we performed IVUS, and here you can see minimal lumen area, which is around 2 square millimeters. This is the ostium of circ, which was stented, and very fair enough low lumen area and wide left main. So we put one 4.0 drug-eluting stent and pot with 6.0, after that kiss and final pot, and this was the final angiographic result. So here, after the IVUS, this is the place at the stent overlap in proximal LAD with MLA around 10. Ostial LAD, it's 1183. Ostial circ was better and bigger than before, and good apposition of the stent in this huge left main. So we are keep controlled this patient, and in our cath lab we have on the wall IVUS Pro criteria, which is a must for left main PCI, that minimal stent area should be more than 90% of distal left main reference lumen without dissection and hematoma, and plaque burden less than 40%, and complete apposition without normal stent, without no proximal stent deformation. And for the end, this is our interventional team from 1991. Here is Dr. Mangovsky, who studied in Sofia, and also in our hospital worked Dr. Lazar Angelkov, who is also study in Sofia. He is still very active in Bijeljina in Bosnia, and every 2 times per year we are organizing in our institution a rotablation workshop with 4 patients. Those who are coming are free to be in the cath lab while we are working, so it is the best way to transfer the knowledge. Thank you very much.